these cells are all uniform in size. There is no great degree of variability in their size, in their architecture. It looks very straightforward, very neat. Whereas in this picture, you have a kind of a confusion, overlapping, irregularity of nuclei, which may indicate that something else is going on, something neoplastic. However, that being said, many well-differentiated follicular carcinomas can look cytologically benign. And benign but atypical adenomas can look cytologically malignant. So there are definitely cases where you can't distinguish follicular adenomas and follicular carcinomas by cytology alone. That's why it's useful to have the ultrasound features. It's useful to look at not only the size of the nodule, but the echo quality of the nodule, the presence of certain ultrasound features which may make you think benign versus malignant or malignant versus benign. So putting all of those things together is a way of arriving at a better diagnosis and deciding what you're going to do once you have that diagnosis. If you're going to proceed with molecular testing, or you're going to proceed with surgery, or you're going to just do nothing and sit and watch and wait. All of these things need to be taken in consideration when formulating the treatment plan, because that's ultimately what we're doing, is we're trying to decide what we're going to do with these patients who have these kind of tricky lesions. Now, when you start talking about carcinoma, in some ways, carcinomas are easier to diagnose cytologically than all these other lesions that I've been talking about. You know, the category 3s, the category 4s. Now we're getting into category 5 and 6, and the cytologic features of carcinomas are usually pretty straightforward. There's usually a high cellularity, so there's lots of cells to deal with. You don't usually have sparsely cellular specimens in carcinomas. There's irregular follicles. They're very crowded. Sometimes you have single cells. You have large pleomorphic nuclei. You have abnormal chromatin. You may have necrosis in some carcinomas. Usually in papillary carcinomas, you don't, necrosis is not a feature that is typically seen. But marked cytologic atypia can fall into the follicular, suspicious for follicular carcinoma or suspicious for PTC category. So again, here I have just a table that that recapitulates the table that I've been that I showed previously with the different zones, the features of goiter versus a follicular neoplasm, where you have scanty colloid in neoplastic nodules. Lots of cells, so high cellularity, scanty colloid. You only have one cell population, whereas in a nodular goiter, you may have multiple cells. You may have some lymphocytes, you may have some Hürthl cells, you may have some macrophages in there, but in neoplastic lesions, you only have one cell population usually, unless you have, you can also have macrophages, but you usually only have one population of cells, of neoplastic cells. The nuclei are enlarged. You may have nucleoli. You may not, but you may. You have uniform follicles. You may have microfollicles in neoplastic lesions. You don't have that honeycomb, nice honeycomb architecture. It's typically that you do not have degenerative changes in neoplastic lesions, and usually these are solitary as opposed to multiple. So here I have a case of a 79-year-old female who had diabetes, hypertension, and hypothyroidism, and she had a nodule in her right thyroid that she presented with. And this was the aspirate. I don't have an ultrasound picture because these are the days before we did ultrasound on our patients routinely. So this nodule was readily seen on physical exam, and this is what the aspirate looked like. And it's very, very cellular. And you notice it has a lot of branching papillae, and there's also chewing gum colloid, which is this kind of gummy, round colloid, and the follicular cells are kind of surrounding it. This is a Pap stain, and you see that these nuclei, again, are also very abundant. They are enlarged. You can even see some grooves in the nuclei, even though this is a very low power view. But for the most part, these nuclei are very optically clear. You can almost see through them. And this is more evident on higher power, where you can see the grooves here. Well, many of them have grooves. So, and this is a membrane change that happens as a result of mutation of the RET-PTC oncogene. And you also see inclusions, which are here. Inclusions are better seen in this area. This is a very beautiful internuclear inclusion. And these are also nuclear grooves, which are seen. These are all features of papillary carcinoma. And when the patient had a total thyroidectomy, the 5.5 centimeter circumscribed nodule showed papillary carcinoma. And the same features were seen on histology: nuclear clearings, grooves, and inclusions. So this is papillary carcinoma, which is the most frequent primary malignancy of the thyroid. These are very slow-growing neoplasms, and they usually go to regional lymph nodes, usually central compartment lymph nodes, which is always why it's important to evaluate evaluate the lymph nodes in the patient's neck when doing cancer surveillance. So as I mentioned, when going over the slides, the cytologic diagnosis of papillary carcinoma is usually a straightforward diagnosis. The smears are usually very cellular. You see papillary fronds with columnar and cuboidal epithelium. You can have cystic change, which can cause one to mistake it for a cystic goiter, which is a theme that I've been repeating throughout this lecture, where papillary carcinomas can present as cystic lesions. But when you see the cytologic features, when you have a cellular aspirate, the features become apparent. You have the papillary fronds, you have this chewing gum colloid, the nuclei are optically clear and have grooves, and you can even see inclusions. So other cytologic features are psammoma bodies, which on ultrasound correspond to microcalcifications. Multinucleated giant cells can also be seen. You can see Hürthle cell change. However, it should be cautioned that the diagnosis of PTC should not be established on any single feature, because psammoma bodies are not specific. And grooves and inclusions can be artifacts. You need to see several of these features, all in an appropriate clinical setting. Another carcinoma that can be seen in the thyroid is medullary carcinoma. That presents as a different cytologic picture. Instead of papillary arrangements, you see numerous single cells in loose clusters. They sometimes appear epithelioid, meaning they look like epithelial cells, or they look like plasma cells or plasmacytoid. They can also be spindle-shaped cells. These, this carcinoma is a neuroendocrine type of carcinoma. It's part of the MEN syndrome. So there is a neuroendocrine component. Some of these cells can be also, the nuclei are round or elongated. They don't have conspicuous nucleoli. The chromatin is finely or coarsely granular. Sometimes you have pseudo-inclusions, but the real giveaway is if you get a cell block and you do immunohistochemistry on it, the calcitonin is usually overtly positive. Sometimes you can see cytoplasmic granules that are red and also amyloid. So here you have the many pictures of medullary carcinoma. See, it looks like a spindly, aspirate. It's and the nuclei are kind of elongated, sometimes cigar-shaped, sometimes plasmacytoid. In this picture, you have these red granules that are apparent in the cytoplasm, and they can also look a little smudgy like this. But for the most part, this can be amyloid, or and the nuclei are very disorderly and arranged and discohesive. You also have poorly differentiated carcinomas, also, which include insular carcinomas, which are very rare. They're not well differentiated, but they're not anaplastic either. So these are, really poorly differentiated carcinomas that comprise 4 to 7% of all thyroid carcinomas. These have a poor prognosis, but they're not as poor as anaplastic. These cells, the cellular picture here is very highly cellular with mostly single cells, meaning that they really are not making anything, they're not forming anything, they don't have architecture. Sometimes you see microfollicles, sometimes they have grooves or internuclear cytoplasmic inclusions. Sometimes they have features of papillary carcinoma or medullary carcinoma. They can have features of both. They're usually positive for thyroglobulin, and they're usually negative for calcitonin, so they're probably not C cells, meaning, or else they'd be calcitonin positive. So a poorly differentiated PTC will have a greater degree of atypia than a classic PTC, but you still see the nuclear changes such as the inclusions or the grooves. You can still see some of that. Insular carcinomas, again, can have a hypercellular pattern. It may make you think about a follicular lesion, but then when you start looking more closely, you see some cells that resemble a medullary carcinoma because they look maybe a little granular. They're single cells, they're more cigar-shaped, or they look a little bit more neuroendocrine in quality, but they are calcitonin negative. Anaplastic carcinomas are also rare, and they are just more de-differentiated than anything else. They don't look like papillaries, they don't look like medullaries. They're mostly single cells with marked nuclear pleomorphism, meaning that they look very large, bizarre cells. They can be epithelioid or spindle-shaped. Sometimes you have squamous differentiation, such as this. You have keratinization, like on the right, where you see the bright orange nuclei, bright orange cytoplasm and inky black nuclei in this necrotic background. And then you also see isolated large cells, like as you see on the left, which have these large, bizarre-looking nuclei. Other neoplasms that you can see in the thyroid, most predominantly are lymphomas and metastatic carcinomas. Lymphomas will arise in the setting of Hashimoto's. They can sometimes be 20 or 30 years after seeing the initial presentation of Hashimoto's. Usually these lymphomas are marginal zone lymphomas or diffuse large B-cell lymphomas. And the patient will present with a very large, diffusely enlarged thyroid gland, in which case that flow cytometry should be performed. Metastatic carcinomas are small, but somehow you see them. There are the most common primary tumors that go to the thyroid are breast, lung, and kidney. So before we finish, I offer a final words of advice, just in closing. Rapid on-site evaluation of thyroid aspirates is very helpful in making preliminary diagnoses and also determining adequacy. It's not necessary, but it is very helpful. This will reduce the non-diagnostic and unsatisfactory specimens, as well as offering suggestions for triage of specimens, such as molecular testing, immunohistochemical studies, or ancillary testing like flow cytometry. So for clinicians, you should know your cytopathologist. You should know who's reading your slides and be able to communicate with them. That is also key. And cytopathologists should know who their clinicians are and be able to communicate with them what their findings are, positive or significant findings, or even just sharing clinical information is also very helpful for both sides in making a diagnosis. So for clinicians, if your patient receives a diagnosis and goes to surgery, it's always helpful to let your pathologist know what the tissue results show. This helps everybody, patients, it helps clinicians, and it helps the pathologist, because we're all working towards one goal, and that is getting the patient the appropriate treatment with the appropriate diagnosis. And feedback definitely works. Thank you very much.